Hi everyone, welcome to our breakout session here at day 2 of the reverse site visit. My name is Tracy Morton. I'm the program manager with TASK for the Technical Assistance and Services Center here at the National Rural Health Resource Center. We're excited to have you in this session where we'll be learning about the COVID-19 response in system-affiliated and independent critical access hospitals. It's a great presentation from the Flex monitoring team. I want to take a few minutes here before I introduce the speakers and tell you about the session a little bit more to just get you oriented into the space that we're in. So we're in a Zoom room now, so a little bit different than the previous session that we were in. The session is being recorded and the playback will be available in the attendee hub shortly after the session concludes here today. So look for it later on today. If you're having any technical issues during this session, please use the chat feature and we'll be sure to help you out. There's a couple staff in here from the center as well as from CVent to offer support. The chat feature is an icon in the lower right side of your Zoom screen that looks like a little kind of comment bubble. If you click on that, and then the chat box pops up. We also want to use the chat feature to ask questions during this session, but I know that our presenters are actually looking for your participation and engagement. So I encourage you to turn on your camera. Let's pretend like we're actually in a real conference room together, and hopefully someday we can do that again real soon. But let's do that, and I think that'll help our presenters with having the engaging conversation that they're hoping for. So take a minute to turn that on. There's a video camera icon on the lower left side of your screen. And also, when we get to the part of asking or answering questions or asking your own questions, you can unmute and mute, or you can use the raise hand feature too, and we can see that, or of course, utilize the chat box as well. We'll be keeping track of time and kind of notifying our speakers as the time goes along, and be sure to wrap up kind of promptly here at the end of our session to respect the sessions that follow today. But I want to take you a minute here and tell you about what this session is, so you make sure that you're in the right place too. So at the conclusion of this session, we're hoping that the participants here, you, can be able to describe the impact of system affiliation on critical access hospitals' response to the COVID-19 pandemic in the areas of workforce, emergency management, and patient transfers. That you can identify areas of support that are needed for both independent and system affiliated critical access hospitals for future public health emergencies, because unfortunately this isn't it, other things will arise. And that you can consider the ways that the state flex programs can support hospitals in dealing with future COVID-19 surges and other public health emergencies. I'd like to take a minute and introduce to you our two speakers today. Megan Lahr is a senior research fellow at the University of Minnesota Rural Health Research Center, and she's the principal investigator of the Flex monitoring team. Megan's work with the Flex monitoring team, or FMT, focuses on quality of care and best practices in critical access hospitals, as well as quality measured data analyses related to the MVQuip project. She has also completed research in access to care for rural individuals, rural caregiving, LGBTQ health and healthcare, and support services for older adults in rural communities. Prior to working at the Rural Health Research Center, Megan worked at the State Health Access Data Assistance Center on a variety of projects related to access, cost, quality, and health outcomes. And she also spent several years working in federal policy for U.S. Senator Amy Klobuchar of Minnesota in Washington, D.C. and in Minneapolis, working on health reform, healthcare outreach, and casework. And I was thinking, Megan, that maybe that's where we actually originally met too, was in Senator Klobuchar's office. Joining Megan is Maddie Pick. Maddie joined the Flex monitoring team in March of 2020, so right at the start and the height of the pandemic. And she's worked on projects related to quality improvement in critical access hospitals. Previously, Maddie conducted a community health needs assessment for a local public health department and researched and compiled a suicide prevention toolkit for rural communities. She also evaluated physician quality measures. Maddie earned a master's of public health and public administration and policy from the University of Minnesota. So I'm going to turn things over to Maddie to get us rolling here today. Thank you.
Thank you, Tracy, and I hope no one got too scared about the participation that we're asking for today. I will explain a little bit more about kind of what we're hoping to get from this session as well. But I want to thank you all for joining us today. So we are going to be presenting on some basically brand new data we collected through a survey this year. And that is where the participation comes in, because we would love to hear some of your reactions to what we found, your input if you have it, as we're developing more products on this topic. So this is the first time we're presenting this, the first product to come out of this work. And so more will be coming on the Flex website But that is kind of where we're looking for you, and we'll have some questions for you all kind of throughout. And then of course, we're happy to take questions at the end and maybe ask for a bit more input if you're not burnt out by that point. So thank you all again for being here today. I don't want to be too much of a broken record because I think we've all heard a lot about critical access hospitals and how COVID-19 has impacted them. But just to kind of set the scene, as we know, CAHs are often operating under different financial pressures compared to larger hospitals. And that financial vulnerability may have been exacerbated by several issues, especially in the early kind of days of the pandemic, halting of non-emergent services. Also, the long-term financial impacts of the pandemic are likely to be delayed because of the temporary funding to rural hospitals, and the real effects of that are kind of yet to be seen. We know that workforce shortages are already more common for CAHs. This has been exacerbated by COVID-19 in terms of illness and quarantines for staff, as well as staff stress and burnout, and the overall workforce shortages across the country that we hear so much about. It's also important to note that rural areas saw different trends in COVID-19 compared to urban areas. So this includes different timing of surges, as well as different lengths of surges. Also, many rural communities have different vaccination rates that may have contributed to later surges of COVID as well. And just to set the scene a little bit when we're talking about system affiliation as well, and kind of where this project came from, where it stemmed from. In thinking about this project, we were interested in looking at the impact of system affiliation, especially on CAHs responses during COVID-19, based on our previous survey last year that some of you may recall, where we asked about how being affiliated with a system or not impacted CAHs response to the pandemic. And what we found in that survey was that generally those that were system affiliated reported that assistance with resources, so things like PPE, group purchasing, and supply chain management, was the biggest impact of being part of a system. And we think that this may also have been sort of related to the large focus on PPE and supply chain issues in the early days of the pandemic. But independent CAHs, on the other hand, noted a lot more mixed responses. So some talked about the flexibility to not have to depend on a system to react to problems, or not having to follow, system guidelines that may not be as applicable to their rural community. But other independent hospitals also said that their response was challenging because of a lack of resources, supplies like COVID tests and PPE, as well as issues with staffing that they think may have been a little bit easier to manage if they would have been part of a system. Additionally, based on previous research, there are some financial benefits to being system affiliated, and we thought that these may contribute to differences in the areas of workforce. So ability to hire staff more competitively, as well as just sort of general ability to react and adapt in a time of crisis. So based on this work, that is why we chose this as the focus area for our survey this year. And I wanted to just sort of call out the purpose, the research question that we're talking about. So the question here is, how do independent CAHs compare to system affiliated CAHs in their response to COVID-19, especially in the areas of workforce and staffing, emergency management, and patient transfers? So I want to talk a little bit about the survey itself and the design. So the survey was fielded from March to May of 2022. And like I just mentioned, it covered three main topics, which were workforce, emergency management, and patient transfers. To survey the CAHs, we selected a random sample of CAHs in each of the 4 census regions. We wanted it to get some geographic diversity, and have it be sort of representative of CAHs nationally. So that's why we took that approach. We started with an email survey. We followed up with phone reminders and gave participants the option to do it either online or over the phone. It also was basically a mix of multiple choice and open-ended questions. And the time frame for the questions, I'll talk about a little bit more when we get into the results. But we either asked kind of about their response to the pandemic in total, or we asked about a specific week for them to think about the week that they had the most COVID patients or the most transfers of patients, and kind of at its worst, what did that look like for them? So in terms of the response, we received completed surveys from 155 respondents, which was 38% of the sample. And all but 4 of them did it online, and those 4 did it over the phone. We had about 72% were the hospital CEO who completed the survey. Others included the directors of nursing, infection control, operations, and quality. And in terms of system affiliation, so we had 25% were part of a hospital system and 75% were independent. And I want to pause on this for just a moment to kind of tell people what we're talking about when we talk about system affiliation, because there's so many different ways that can get defined. So the way that we asked this was about ownership. So this is 25% were owned by a hospital system or another hospital. We also asked about contract management and group purchasing to get a sense for how many that were maybe not owned by a system had those kind of relationships as well. So of those independent hospitals, 21% of them were contract managed, and almost all of them said that they participated in some sort of group purchasing agreement. So 95% said they did some sort of group purchasing. So I just want to put that out there, that for the purposes of our presentation, when we're talking about system and independent, we're talking about ownership, but there are kind of these different levels and different affiliations as well. And I wanted to show you kind of where our respondents come from in terms of the responses by state. And so each of these numbers just represents the number of completed surveys we got from that state. This is not meant to emphasize any states that we have, big numbers from, or call out any states that didn't have many responses, because they were all sampled a little bit differently. But just to kind of show where the data come from, and we were glad to see, we had a good mix of geography. Obviously, there's also a big concentration in the Midwest just because of the number of CAHs and all of that we all know about. So I am going to turn it over to Megan to talk about some of our results that we found.
Great, thanks, Maddie. So first, this graph, we're going to go through kind of a series of graphs. And again, we invite you to jump in and ask questions or make comments when we start asking questions of all of you. So this first graph we're showing talks about the type of flex support received by the hospitals. And so we asked, multiple choice question, what type of support did you receive from your state flex programs? And got a lot of really good information. This is something that we're always trying to find out in our projects. How is this connected back to the flex program? And so here we see that financial, that was the response that we heard from all of the hospitals the most. The caveat here is we aren't quite sure, when you ask a large survey question, specifically what they meant by financial. So this could potentially mean, did they receive grant funding, like a small grant from their state flex program, or help navigating a lot of the financial assistance. We know that a lot of the state flex programs spent a lot of time helping their hospitals with all the federal funding that came out. And so I think both of those are probably in this financial section here. The different colors represent kind of the independent hospitals and the system affiliated hospitals. And so you see some differences here by system affiliation. A higher proportion of system owned CAHs said that they had received situation updates or briefings. That one stood out a little bit. There's also, a relatively low portion of folks that said, I don't know, which is really promising as an indicator of kind of the visibility of the state flex programs. And so that's something I think we are really happy about too, to see that folks knew when the state flex programs were helping. And so that was great. And I think, of note is that this distribution of how many types of support were selected is really pretty high. And so we know that the state flex programs were doing a lot in this time and across, the past few years. And so it was really great to be able to capture some of that here. And so, as we said, are there any reactions to the types of support that is reported here, or kind of experiences in uptake or kind of the use of different supports based on system affiliation? Like Maddie said, we'd love to hear from all of you if there are things that jump out as puzzling to you, or just something that you really resonates with you about kind of what your hospitals used or what you were doing. Any thoughts there? Kyle saying in the chat that seems accurate. Thank you.
Yeah, I'll just make a comment about that. So for the COVID response, a majority of our response was with financial assistance and financial support, and then education around what was going on with COVID and the situational briefing. So I'm not surprised by what this graph is showing.
Great. Thanks so much.
Yeah, I went to that the financial support, Megan, since the Small Rural Hospital Improvement Program, our SHIP, is based at SOARS, and so many SOARS are flex programs, that there might have been, some perception that
Yes,
the SHIP funding for hospitals for COVID relief was from flex.
yeah, that was something in our previous survey when we had asked questions about, flex program support, that say, oh yeah, SHIP did this. And we were, we were able to tease that out a little bit more, but definitely I think in working with State Office of Rural Health, sometimes folks are saying, well, that's the person I go to. And that person may be doing wearing a couple different hats.
Yeah.
Absolutely.
But that's the situation updates or briefings. That's obviously the most dramatic between independent and system owned.
Mm-hmm. Great.
And I imagine the system-owned hospitals have the resources, the capacity to, be filtering that information and translating it down to providers and staff.
Yeah, absolutely. And let's go to the next slide, Maddie. For those that selected more than one type of support from that previous question, we then asked them, which was the most helpful of those different types of support. And so this shows, they could only select one in this case. And so here you see that the independent hospitals more often said financial, which I think really, at least to us, makes a lot of sense, right? The support that these independent hospitals, they may not have their system to be doing a lot of that work, especially with a lot of the federal funding and kind of working through those, a lot of the challenges and communication issues that, here's all this money coming to your hospital. What do I do with it? What do I need to do? How do I need to get that money? What do I need to report? Things like that. And so I think this was something that was really interesting to us. And same looking at that, the situational updates and briefings too, for the system owned, that really, again, stood out as kind of what they said was the most helpful. Let's see here. And the same caveat with the financial. Again, we don't know exactly what that means, but I think the implications are there that, the folks are really looking to see what was most helpful from their state flex programs. We can go to the next slide, and this will kind of continue this conversation. So this is a throwback. This is of a 2020 State Flex Coordinator survey that our partners on the Flex Modern team at the University of Southern Maine completed in 2020. And so this was when all of you state flex programs were asked, what are you doing to support your hospitals? And granted, this was in summer of 2020. And so it was a lot different than kind of looking over the past 2 years, which we've asked folks. But it's kind of interesting to see. We wanted to just pull this up to see what support the state flex program said they were doing and kind of compare that to what now the hospitals are receiving and what they found most helpful. And so I think the question here we would have is, how have things changed over time for folks who have been here for the past couple of years, kind of since this was a lot of education and dissemination of information and technical assistance. Have the things that you're doing changed over time? to support your hospitals better. Perhaps as we've seen the transition from the most immediate needs at the beginning of the pandemic to the long-ranging issues more like workforce. So have things changed over time in what you're doing as a state flex program to support hospitals?
No, I think this looks very similar to what at least we're doing right now.
Mm-hmm. Great, thanks, Kyle. Any other thoughts? All right, well, we'll come back to more questions. We can go to the next slide and jump into a little bit on workforce. Oh, thanks, Jennifer. Jennifer agrees with Kyle, really similar. And so looking at workforce, we asked folks, which position is the most challenging for recruitment, and ask them to, which positions were challenging, not the most challenging. And so they could select any of these, as many as were applicable to them. And by and large, we see here, and to no surprise to us, that nurses was the most difficult for our critical access hospitals to recruit. That's something that existed before the pandemic and is still really important, as we all know now. It was interesting to see that respiratory therapists was a bit higher in the system hospitals. So that's something, we'd love if folks have thoughts on that as far as recruiting and why that might be. The other listed here, some of those other staff positions included environmental services, dietary services, folks that just said all or various different groups of these staff positions, medical assistants. There were a couple that said things like IT or finance, but overall, these were kind of the largest ones that stood out here. But really what this tells us and what we know is that there were really a lot of challenges with recruiting overall. We also asked about retention in the same format for a lot of these different categories. And there were fewer responses from folks that said they had problems with retention, but it was still a problem. I think part of that is, I think it's a little bit harder for someone on the spot to answer, how hard is it to retain these different types of folks? And so that's something we realized a little bit, but it generally followed the same pattern of the folks that were hard to retain as well. Clarissa noted that many respiratory therapists left hospitals to go traveling, which paid a lot more, and that absolutely, that makes a lot of sense. And the need for our respiratory therapists increased with COVID. Absolutely, and that was one reason that we asked them that, because that was something we anticipated that folks would have a need for. Yeah, Tracy.
I was just wondering, Megan, if you know any comparative data about what it was like before the pandemic for positions that were hardest to staff?
We don't have a specific that kind of broke it down like this. I think the biggest that we know is that nurses is kind of the long-standing data is there, that rural hospitals have had nurses. And so that I'm not sure as far as like if folks were ever asked, these different types of positions, that would be really interesting. And I think, yeah, that's a good note for us to kind of dig a little bit deeper to see. But I'm not sure that we will be able to find anything that kind of goes into all those different pieces. But I think it's worth checking and highlighting those differences. Great. Well, we can move into our next piece. And this talks a little bit about the partnerships that folks were doing for emergency management. And so we asked, is there anyone else that you're working with as far as emergency management? This is something we were interested to see how system hospitals and independent hospitals worked to see if they worked differently, who they worked with, and try to see, how those relationships were built and hopefully sustain as far as looking ahead and how folks can work together in future public health crises as they may come up. So this shows hospitals that are in a system were asked if they worked with other hospitals in their system. Obviously, independent hospitals weren't asked that question, so that's that top bar there. A lot of hospitals were obviously working with other hospitals in their system if they're system owned. But local public health, no surprise here, that was the biggest outside partner that folks worked with. I think some good relationships to be built. State hospital associations, again, as state flex programs and folks working with them, we're not surprised by that. But great to see that those are resources that folks are working with and using. And I think especially with a lot of the legislation that impacted critical access hospitals during the pandemic, this makes a lot of sense. I think the hospitals outside the system, I think that was really great to see that, 70% of independent hospitals worked with other hospitals. And I think when we get into, Maddie noted those numbers, the really high numbers of group purchasing and some things like that, those may be areas that folks work together. But as far as emergency management, it's good to see that, folks are just working together and have these longstanding partnerships. There aren't any significant differences by system affiliation besides the different types of hospitals they worked with. But overall, it was just interesting for us to see kind of what this looked like. And then the last section at the bottom, that other, that included things like local or state healthcare coalitions. That was the largest other group that we heard about, but also things like schools, correctional facilities, churches, and other community organizations were mentioned as kind of those other partnerships. We can go to the next slide. This is one of the quotes that we had, and I thought we thought this was really illustrative of kind of the work that's going on. But that one of the positives of the pandemic is our area critical access hospitals have worked closer together than ever before. CEOs from 5 different hospitals, competitors, get together via Zoom once a week to go over issues and learn from each other. We've also done joint marketing, for example, on masking and vaccinations, and it's common for our infection control nurses, CNOs, and others to collaborate and share. Again, this wasn't surprising to us, and I'm sure it won't be to many of you, but it's something that really illustrates kind of the work that all of you are doing to support and showing that through the hospitals was really great to see. So we're happy to share that. I'm going to pass it back over. Jack King says this happened in regions of Montana. Yeah, absolutely. Thank you. Maddie, I'll pass it back to you.
Actually, before I go to the next one, I just wanted to also say that I was thinking that this tied in really nicely to what John Gale was talking about yesterday, for those of you that were in that session, and thinking about what feel like pretty tangible ways that hospitals can work together that are normally competitors, but trying to kind of get the same, a united message out to their communities about masking and vaccinations, and also learning from each other as the pandemic has unfolded here. So just want to make that connection for those of you that were on that presentation as well. So the last section of results that we have for you is all about patient transfers. So starting with patient transfers out of CAHs. So this is where we asked participants what was the highest number of transfers out of your CAH that you had in a single week. So we were looking for kind of at the most, how many transfers went out of your hospital. And so you can see that the distribution here for independent and system is a little bit different. A higher proportion of system hospitals said that they had 11 or more transfers out at their highest week. And we weren't too surprised by that because we thought, independent hospitals might be more likely to keep their patients if they just don't have that system relationship for transfers. And we did also ask some follow-up questions to this that I wanted to mention briefly. So we asked a follow-up question about what was the furthest distance that you had to transfer a patient. And 78% overall selected 100 miles or more, which it made it clear to me that we needed some higher categories in our survey question as well. Honestly, I was a little surprised by that. I'm guessing that the rest of you may not be surprised by that. And this was slightly higher among independent hospitals and system owned, which kind of makes sense to me. But I just thought that was kind of a stark finding. And then we also asked about the biggest barrier to transferring patients out, and we gave them a number of options after kind of consulting with some folks on our panel. And 92% of them said that the biggest barrier was just finding a hospital to take a transfer or finding a bed that was available, which makes a lot of sense. And that's probably what you all have heard as well. But it was interesting to see that was by far the single biggest barrier compared to things like transportation and, communicating with the receiving hospital and things like that were some of the other options. Similarly, we asked about what was the single biggest facilitator for transfers? What helped transfers work well? And the answers to this one were a lot more mixed compared to that barriers question. So these were the categories that we had given them. And we saw that a higher proportion of system-owned hospitals said care coordination was the biggest facilitator. And more independent hospitals said that the hospital relationship was the biggest facilitator. So it was just kind of interesting to see those differences. It may be just that the system hospitals, you know, their relationships with other hospitals in their system is sort of built into their structure. So that may not be something that they are consciously thinking about as facilitating those transfers. But I would be curious to know if people have other thoughts on that as well. And then, so the other responses here kind of had similar percentages, not a lot of big differences between system and independent. And I just wanted to note too that this other category, we had people fill in what they've meant for that. And most of that was, they said they would just transfer to wherever there was a bed available. And there wasn't really like one thing that helped facilitate that. It was just kind of whatever was available. So. And then we also asked about transfers into CAHs. So here we have, again, a sort of different distribution, both from the outbound transfers and a difference between independent and system hospitals. So first, I just want to point out that a decent proportion of hospitals, both independent and system hospitals, said that they had gotten 0 transfers in over the last 2-ish years. Which I thought was interesting. And again, maybe not surprising to you all, but I was a little surprised by that. Like, they haven't gotten a single transfer in 2 years. But there you go. But similar to outbound transfers, a higher volume of inbound transfers among system hospitals. You know, we see this, the way that this curve is, and most of them said they had 3 to 5 transfers in. A number of them also had more than that. Whereas for independent hospitals, their responses were really clustered between like 0 and 5 transfers in, which I think is in starting to look at some of our other data from the survey. I think some of that may be related to kind of reverse transfer strategies, especially among system hospitals, where they would transfer out their more acute patients and take in less acute patients. But I'd be curious to hear again from you all if you have other thoughts on why that might be. But seeing as that is kind of our last section of results, I'll move on to just kind of sum up what we've talked about and the key takeaways, and then we can see what questions you have and get some more thoughts maybe from you all. So again, we're still very much in the beginning phase of analyzing these data. We do still have qualitative data that we are analyzing that we think will really provide additional context to what we've talked about today. But overall, there weren't a lot of big stark differences between system and independent CAHs, which, you know, surprised us in some ways. But we also think like this lack of difference may be related to the small sample size, especially of system hospitals, when we had a lot more representation from independent hospitals. But again, just kind of these 4 main categories that we had talked about in terms of flex support. Financial support was the most helpful to independent CAHs, which isn't super surprising, but it was helpful to see that reflected in these data, and helpful to know that they especially needed that support from the state flex programs. In terms of workforce, we saw that the respiratory therapists or recruiting respiratory therapists was more difficult for systems, or more of those hospitals said that they had a difficult time recruiting respiratory therapists, which was a little bit puzzling to us why that would be different between system and independent, but it could be due to the different types of services that are provided. So perhaps independent CAHs already have services that that are provided by respiratory therapists, and system hospitals may not because they have other hospitals that would do those services. So kind of an interesting finding there. In terms of partnerships, we saw that most system affiliated CAHs worked with other hospitals in their system, and over 2/3 of independent CAHs also worked with other hospitals, as well as a number of other different types of partners. And in terms of transfers, we saw that system CAHs were more likely to select a higher number of transfers out, and independent CAHs were more likely to have 0 or very few transfers in, sort of that opposite relationship.
Maddie, we have one question from Jack. Were we able to learn what the Flex financial support looked like? I think the answer overall to that is no, we don't have a lot of information, but Maddie, can you remind me if there's anything in the qualitative data that might give us a little bit more?
So unfortunately, we didn't ask specifics about that, but there were some, very open-ended questions where folks might have offered more information. So the answer is likely not a lot of more detail, but we may have some insight from a few hospitals coming up. Yeah, good question. And then I just wanted to kind of leave us on another quote from one of our hospitals in the survey that just says, "We did our best. Our staff who stayed are exceptional people. We are here for our community and will stop at nothing to stay open," which I think really speaks to what we hear from a lot of CAHs and rural communities, in that they're, resilient and are really committed to their community and also to their staff. I think that was great that they recognize that and that their staff have really stepped up to serve the community as well. So I am going to pause there and I'll open it up first to any other questions for us. And then I have a couple of, of discussion questions for you all if you're willing to share some of your thoughts. So questions for us.
Would you be willing to go back a few slides to the biggest challenges to transfers?
Mm-hmm. So this one, let's see. So we have these are the facilitators to transfers.
Okay.
Is that what you're thinking about?
Maddie, you just spoke through the challenges, I think, briefly. And so,
yeah, I had talked about it, and the options that they had were quite similar, but not identical to this. But this is where I think it was like, let me see what the number was. 92% of them had said that the biggest barrier was just being able to find an open bed or a hospital that could take a transfer.
Okay, thank you.
Yeah.
I found this slide interesting, that the system-owned hospitals said that having the care coordination really, dramatically helped with that transfers outbound. But then for hospital relationship, I thought the system-owned would have been higher, that, they have a relationship with a tertiary hospital or other hospitals. So that one kind of puzzled me.
Yeah, and I don't know if that's, I mean, that was kind of my best guess as to maybe it just isn't top of mind because it's sort of built into how they are operating, that they don't necessarily think of those as like other hospital relationships because it's more of their system.
And maybe it also went in the system policies response. That was a separate question for those system hospitals, if that they put it there and thought that instead.
Yeah, we did have this separate option about system policies, and that may have it's possible that it sort of pulled some answers away from the hospital relationship because it fell under system policies. So it's hard because they're not always exactly comparable between independent and system. As much as we tried to keep everything as identical as possible. But.
Yeah, and then Oh, go ahead, Kyle.
Well, I just wanted to add too, and I don't know, but this is just a thought, that some of our smaller independent hospitals don't have a dedicated person for care coordination, where some of the system owned, they are better able to have a person just dedicated to care coordination.
Yeah, and I think some of that comes back to the financing, right? If care coordination isn't reimbursable, certain things that a system affiliated hospital may have a little bit more flexibility or a little bit more to work with to do. Great point.
Yeah, that's a great point. And maybe, those 14% of independent hospitals that said care coordination, like maybe those are the only ones really that have that as support. So that's a great point.
It's obviously too late for this, but and we spend a lot of time with our peer groups here, because within the 48 hospitals that we have, 47, there is such a broad disparity in size. So it would really be interesting to extrapolate this data into different sized CAHs. In Montana, the only CAHs that held on to COVID patients were the very biggest one, who had, care coordination and respiratory therapists and but as you get smaller and smaller and smaller, they just didn't keep anybody. I mean, they just, they had to get them out and go someplace else. So it would be really interesting to see how this data lined up against different sized hospitals.
And would you think, Jack, that would be within the system and within the independent, or across all of them would be most interesting? Because we might be able to take a look at some of that.
In Montana, we have so few system-owned
Sure.
hospitals. We're getting more all the time, but we had 2 hospitals that responded in Montana. Chances are really, really good neither of them were owned hospitals.
Yeah.
If you can let me know which one it was,
Well, and I think too, we can look at the number of beds for each of these hospitals, and we could group them and run kind of analyses by that. So that's a really great idea for us to kind of take as, outside of even independent and system owned, just the size of the hospital, and if things look different based on that too.
Right.
Yeah, and I think also on those inbound transfers too, because we were hearing that in Minnesota, and I could see where in the system, they're all in the same EHR, that they're able to look at the volume, and the system likely has a large hospital treating COVID patients, and that's where they've centralized the care. And there was, that during surges that they needed so many beds and staff that they were transferring.
I think in Montana, the majority of inbound into a CAH would have been from a system affiliated hospital that was getting non-COVID patients out of their hospital. So, and again, our numbers are just so small. It's really hard to apply a lot of this, but the good news is I'm having a hard time remembering far enough back when we were in the middle of a really bad surge. So that's a good thing.
Yeah, we did also ask some qualitative questions around transfers. So we asked about, what was the main reason that you had folks transferring out and also in? And so those, again, not to give too much of like a teaser, and you'll just have to tune in, but we are still analyzing those data. So I'm curious to see kind of what those show in terms of those like reverse transfer strategies and how folks were able to do this, as well as how that looked different for, transferring out and transferring in. So we do have a little bit more detail on those that will be forthcoming. Well, I know we only have like 2 minutes left, so I think I'm just gonna wait and see if anyone else has other questions for us. I did have a few questions for you all that I'll put up in case you want to ponder on your own or discuss with your peers sometime. Also, if you have other thoughts on kind of things you would like to know about the difference in response between system and independent CAHs, we'd love to hear from you if you want to reach out after the presentation.
Well, thank you, Maddie and Megan, so much. We really appreciate your time. That was fascinating. I think it gets all of our wheels turning about, what's going on with the hospitals in the state. I was thinking about the hospitals here, even in my community, which is urban, but some friends that are providers and thinking about their anecdotal stories over the couple of years too, about what was going on there too. It's interesting just to kind of think that all through and compare. So thanks for sharing the preliminary info. I'm really excited to hear about the teaser there, Maddie, about what's to come next with the rest of the information too. So we'll look forward to that brief getting released. So thanks everybody for joining. We're actually adjourned for a break. We have a 15-minute break now until 2:30 or half past the hour in whatever time zone you're located in. And then we welcome you back at 2:30 Central to a plenary session about the update of the Flex program core competencies. So look in the attendee hub for the link to join that session at 2:30 or half past the hour, and we'll see you back from a break at that time. Thank you all.
Hey, Scott, were you able to hear?